I hope you didn't get too excited about the title of the future of outreach. I'm really thinking like within the next 5 years. I'm not going to be talking about teleporting or science fiction or anything like that, but really some ideas about the directions that outreach can head in. And this is very much a team effort. Most of the audience, in fact, belong to the outreach programs at CAMH. In particular, Eva Surhall is the director of outreach, and we have most of our operations team here. Robert Cook, who's the director of the Ontario Psychiatric Outreach Program. Denise Canso is there. Lots of consultants who've worked in the program, like David Goldblum is in the audience. So it's very much a team effort, and I'm going to be talking about our collective work today. So as the title suggests, I'm going to talk about the future, but one of the ways I'm going to do that is also to reflect on some of the limitations of outreach as we've practiced it so far, or at least some of the ways that some of our methods have become outdated. Especially when we think of outreach as something that increases access to care, but we don't think about other dimensions of care, other aspects of quality, and also what it means to do a consult and then not know what happens to clients at follow-up. And I want to suggest a number of things. So this is sort of the nutshell of what I'd like to talk about. That I see the best path forward to meaningful outreach, and by meaningful I mean that results in good patient outcomes and makes a difference in terms of population health, that we have to look at a number of principles. Culturally safe care through outreach, community engaged care, this is a long list, so I'm going to read it, measurement-based care, which is a move that we're all making in our practices, looking at continuous quality improvement, and most importantly, when I think about all of the disparate ways that we've done outreach at CAMH, thinking about integrating the outreach modalities that we use. Also looking at methods that we have available now for health systems planning, especially regional planning. So we do a lot of work. We've been called by someone in Thunder Bay the flyover service, because we fly over regional centers in order to do work in smaller communities. So what would it look like to do more systems planning and engage with regional partners? And then finally, especially since we are part of a university, the educational aspects of outreach. And I think that's something we've been very strong in, but how can we increase the strengths in education and in faculty development? Okay. And I had to make a decision, as we all do when we give a relatively short talk, between breadth and depth. And I thought this was an opportunity to talk about the work that team is doing across different programs and research projects. But I have loads of references at the end of the slides, and if you want to talk in depth about any of these areas, I'd be more than happy to. Hey, welcome. Okay, and we're all familiar with the challenge, and in fact, Paul Kurdiak and his team have led a lot of this research to really highlight that despite the burden of mental illness in our province, in our country, especially in rural areas, there's a higher burden of mental illness in those areas, we have a real lack of access to psychiatric care, again, especially in rural areas. And that's largely a problem of a maldistribution of human resources. And that's something that for a long time outreach has been trying to address. So flying into different communities, driving into different communities, there's many origin stories to that. A lot of intrepid psychiatrists who really wanted to make a difference in communities, leaving both CAMH and the University of Toronto back in the 70s, going out to smaller places. The program was formalized in 1999 under the leadership of Brian Hodges, who created the Ontario Psychiatric Outreach Program. And in that, he brought together a partnership of 3 already existing clinical programs. So one was at the University of Toronto at that time, now CAMH, the Northern Psychiatric Outreach Program. The Northern Ontario Francophone program at the University of Ottawa, and also the Extended Campus program at Western. And there was some involvement along the way from McMaster. And that is now a Ministry of Health funded program that supports psychiatrists to go out into these communities. NPOP largely goes to eastern and northwestern Ontario. And I'll give you a sense of our The main data that we've collected, at various times in the past there have been attempts to collect data within outreach, but mainly we look at access in terms of the number of days of service we provide and the number of consults that are seen, number of client visits. So we provide about 230 days of service per year to 8 communities and see about 1,400 clients during that time. We also provide a lot of education, so 270 days of resident education. In addition, we help support Health Force Ontario to fill their urgent locum program, and that's an additional 600 days of service per year. The program in Nunavut has similar roots, going back to the 1970s, of people going to provide service mainly in Iqaluit, and that's more formalized now. We serve 10 communities twice per year, and we have a monthly visit to Iqaluit. And I also started a collaborative care, more of an indirect care service to the mental health nurses across Baffin. So we see about 1,400 people in person per year, and I do 1,000 indirect consults per year by, I like to say telepsychiatry, but it really means telephone, which works very well to bridge some of that distance. So what's the evidence for outreach? That's a lot of effort, a lot of sending people, flying around and driving around. What is the evidence? There actually was a Cochrane review of outreach, but it's going back quite a ways now to 2004 by Gruen, who's an Australian physician. And he and his group looked at outreach across different areas, different specialties of medicine. So it wasn't specific to psychiatry. And at that time, they found 73 global outreach interventions that met their criteria. 7 were from Canada. Only 1 was in psychiatry of the Canadian ones. That was by Nick Cates, and it was outreach within Hamilton to somewhere else in Hamilton. So they looked at urban and rural outreach. But no Canadian studies, including that one, met their final criteria for inclusion. What they did, the main studies that were included were from the U.S. by Wayne Caton, who people may be familiar as the sort of founding figure in collaborative care. But what they found in general with outreach is that this model of a shifted outpatient style of outreach, where you set up a clinic in a remote location the way you would in your home community, it did increase access, and our numbers show that as well, but there was no research on or evidence of other outcomes like improved patient health or improved system performance. When they looked at more complex, multifaceted forms of outreach, usually ones that connected with primary care or other interprofessional team members, they did find that outreach could be very effective, and there are very good outcomes, or reasonable outcomes, in terms of improved health, more efficient, guideline-consistent care, and less use of inpatient service. So there really is just a lack of evidence in general, and it's also older evidence now. And our group is in the process. We've started a systematic review to update that review. And to give you an idea, we're only focusing on psychiatry, not all of the subspecialties of medicine. We've found 3,500 publications. So the literature certainly has increased. And I actually was hoping it would be done by rounds. We submit this so early that it's not quite done because it turned out to be so massive. And what we're doing is organizing the outcomes in terms of the 6 quality of care domains. So equity, client-centeredness, safety, effectiveness, timeliness, and efficiency. And these are the HQO quality domains that have been adopted. And so we want to see what the current evidence is for outreach, including modalities of telehealth and telepsychiatry. And in our own program, we're also interested in starting to collect some of this data. And in fact, OPOP is having conversations about collecting more outcome data as well. So I think everybody has a common goal in thinking about the impact that we're having beyond numbers. The other issue, in addition to understanding the outcomes of the work we do, is how do we integrate it? So we have these different programs, telehealth-mediated outreach, fly-in programs, which are the oldest ones, and a program that I'll tell you about called ECHO, Project ECHO. How do they and how should they be integrated? So we're hoping to use some of that outcome data that's growing in our own program to shape how we deliver programs and looking at whether we see an impact when we integrate them across those different ways of reaching out. And this is a map. Thank you to Christine. We actually have a geographer on our team, which is very helpful. If you look at this, and it's going to be hard to read, so I'll draw your attention to two things. The red is telepsychiatry. We're like all over the place. 250 or 225 communities over the last year. The black dots are of special interest to me, and those are the communities where we do all of the modes of outreach. We have the fly and drive-in program, which means we have long-standing relationships. We offer telehealth, and there are people in that community, primary care providers, that participate on ECHO. And increasingly, we have access to health administrative data through ISIS, and I'm very interested in how those communities fare compared to ones that get only one aspect of our service. I'm going to come back to that map. So I'm going to tell you about I told you about the fly and drive-in. So two other aspects of the outreach suite of services. One is telemental health. We're really trying to rebrand from telepsychiatry to telemental health to acknowledge that we want to move towards interdisciplinary care, and ECHO Ontario. But first, just a little. This is my annoying aspect of telehealth plug. This is not new. We keep calling it innovation, but really we're actually pretty slow to the game to introduce technology into medicine. This is the cover of a magazine in 1925, a physician who also had an engineering background and an interest in radio. And he imagined this device that he called the tele, so tele means distance, and dactyl meaning touch. So distance touch machine where physicians could use this, and he predicted by 1975. So we're kind of behind. Having said that, mental health and psychiatry are the highest users of telehealth. Among all of the Ontario telemedicine network consultations, mental health and psychiatry account for about 70%. So we're better than everybody else, but we're really not good enough. I know David Goldblum would back that up because he's written a column about that very thing. Okay. I'm going to gloss over some of the existing research, except to say that there is now there's very robust evidence for the use of telepsychiatry, both in terms of its acceptability and feasibility. So it can be implemented, it's relatively easy to implement, it is reliable in terms of diagnosis. There are some caveats to that I could mention, but it's reliable across the spectrum of ages and acceptable. In fact, in the acceptability studies, one of the interesting things is patients find it as acceptable, and they rate the therapeutic alliance equivalent to meeting in person, which hurts the ego a little bit. It's providers that rate it a little bit less. So we find it more uncomfortable, or tend to find it more uncomfortable than our patients. It's very acceptable to them. It's also very effective, and there are now, not a lot, but a number of randomized controlled trials, particularly in the treatment of depression, and the VA in the States has really led the charge on this research about offering treatment in person versus over telepsychiatry, and they found equivalence of outcomes. There's one Canadian study, Dick O'Reilly, who I believe was at Western, who looked at a mixed group of psychiatric patients. So there's some, and that was a randomized controlled trial as well, in terms of consultation, not treatment. Oh, I know something that maybe I'll save it, but that will be of interest as we ramp out the provincial strategy around psychotherapy, the evidence for delivering psychotherapy by telehealth. That is something that's in its infancy in terms of randomized controlled trials and so on, but there's some promising pilots. So telemental health at CAMH has grown quite a lot over especially the last year. We've had a 64% increase compared with the year before, and seen 2,200 consultations, and lots of availability of physicians willing to do telepsychiatry. So this growth, there's a demand, but also through the Medical Psychiatry Alliance, we've had an infusion of funds to support physicians to do this work. Remuneration's been a big driver because sometimes the no-show rate can be higher in telepsychiatry. And as I said, we served 225 communities. This is, we've developed, or redeveloped actually, a client experience survey. And again, as with the literature, people are quite satisfied with the service that they receive over telehealth. And one of the things that's interesting, we just did a factor analysis of the items on that survey, and they map really well onto the quality of care domains. So although there are limits to client satisfaction surveys, it is going to help us look at those different dimensions of providing service. But what do we provide by telepsychiatry? That's a different kind of question. So again, we've got lots of access, growing access. But what do we do? These are the three general models of telepsychiatry. One is a traditional referral model, which we don't really practice. That's, somebody takes on a roster of patients via telehealth. The second model is more what we do in the States. They still call it consult liaison psychiatry, where the primary care provider refers, the patient is seen via telehealth by a psychiatrist, recommendations are made, and those are sent back to the primary care provider to implement. That's the bulk of what we do, and that's really how telepsychiatry has grown over the last 10 years at CAMH, maybe a bit longer now, and in many ways as an outgrowth of our outreach service. So when you weren't in the community, who could see the patient? And it was seen as a more stopgap measure. What we're now moving towards over the last few years is a more collaborative care model. And there's also evidence. Fortnoy and Hilty, again, through the VA, have done a lot of this work. So we're moving towards this integrated care model where we match a psychiatrist with the distal community, usually a family health team, so that they can provide both indirect and direct care seeing patients. And it's been a bumpy road. Dr. Goldblum's one of our staunch supporters. But we really think that in the long run is going to result in better continuity of care for patients. So what we're starting to look at is outcomes for patients, depression scores, disability scores, anxiety scores, and also the implementation of recommendations, because we all know when specialists make recommendations, there's about maximum a 30% uptake of those recommendations usually. So keep that in mind. I'm going to show you a slide about echo and recommendations in a few minutes. But we're really interested. Our hypothesis is that this kind of integrated care will result in better outcomes, largely through more recommendations being implemented because there's an existing relationship between providers. Okay, I'm going to switch gears and tell you about echo. Who here has seen an echo before or participated? Yeah, of course, our team's like, yeah, seen way too many echoes is what they're saying. All right, I'll tell you a bit about echo first, just so you understand the model. So Sanjeev Arora is a hepatologist in New Mexico who really originated echo. And he was treating hepatitis C. He's in Albuquerque, and they have a very similar geographic picture to Ontario. He was driving all over the place, had these very long wait lists, and patients were doing very poorly before they could finally get treatment. So what he did was find a kind of champion or a clinical leader in each of the communities he was working with, and he gathered them together by televideo conferencing on a weekly basis, where he could go over guidelines with them in the treatment of hepatitis C, and he could also help manage through this indirect care. They would do case presentations. And he published the results in 2011 in JAMA. And the patients who were seen in this indirect way through consultants who were supervised through ECHO actually did better than patients in tertiary centers, which was a radical improvement over what was happening before. So he really saw the strength in these means and has developed the ECHO Institute to apply this to other areas, not just of medicine any longer. It's in the prison systems, it's in education, it's really grown out from New Mexico, and he has a goal to touch 1 billion people by, what is it, Peter, 2020? 2025? Okay, we still have a few people to go, but I think you're all touched now. So, yeah. So he really does see the kind of multiplication effect of this. And we also, when we went to New Mexico, we call it the Kool-Aid. We first saw echo and we were like, oh, there's the Kool-Aid. But after seeing it and now implementing it at CAMH, we really see the power of this method for knowledge translation and community building. And the spread has been global. There are over 180 echo hubs now. And I'll give you more of a breakdown of what actually happens during echo. This is a picture of our Echo Ontario Mental Health. So we started that in 2015. We're in our third year. Each year has about 36 sessions, and on a weekly basis we have a session that lasts 2 hours, and we bring together usually about 30 different sites, and we have a curriculum that we've developed through a needs assessment with those sites, what they feel they need to know in mental health. And of that 2 hours, we do a 20-minute didactic session based on that curriculum. So you can see that's really not the meat of echo. The rest of it is those sites. We call it a hub and a spoke. You'll see the picture of us there at the hub. The hub is psychiatrists. We have a child and adolescent psychiatrist, family medicine, social work, addiction medicine, and a librarian, which is a kind of unique feature that we've developed on echo. So we do the didactic presentation, but then the spokes, all of those community sites, and you can see them like they're little Hollywood squares up there. One to two of them will bring an anonymized case, so a real case for presentation. And there's a whole flow or process by which we get recommendations from all the spokes on that case, and then also from the hub. And then that is tied together. There's a case formulation, and the recommendations are packaged for the spoke and also put on a community of practice website for the other participants if they have similar cases. So it's a way in the didactic of reviewing and disseminating evidence-based care and guideline-based care, and then the case allows them to apply that to their absolutely complex cases. Like, I've been amazed at the cases that these primary care providers are managing alone in the community. And I'll tell you a bit about the evidence. This is, the University of New Mexico talks about this as the learning mode of echo. They call it a learning loop. So that with that hub and spoke model, it's not just knowledge going out from the expert hub, knowledge is coming back from the spokes, who know much more about their context. And then they also teach each other. So there's this real diffusion of learning. One of our research interests is finding out what the learning theory is. Like, learning loops is not really a learning theory, and for any of you that are familiar with adaptive expertise, that's an area that we're looking at. So how they learn to manage complexity, because no single guideline is really all that helpful to them. Another important dimension is this idea of the community itself and the community of practice, that they're really working in a shared area of interest and getting a lot of support from each other. And that's not something that the University of New Mexico has researched all that much. So that's another area that we're interested in, particularly around isolation and health provider burnout. And then the other side of the coin, actual satisfaction and joy in work. Joy in work, who would have known that? We did, a couple of years ago, we were interested in the evidence to support the use of echo. There hadn't been a systematic review. And we adopted Donald Moore's evaluation framework because it's a continuing professional education framework that looks at outcomes at multiple levels, because we were interested, this is an educational modality, so people often accuse educational modalities of having no real world impact. But so we're looking at, all the way from participation. So do people like it? Do they participate in it? Do they learn from it? But then, does it really enhance their sense of competence, their actual clinical performance, and most importantly, does it lead to good patient outcomes? And the holy grail, which you'll see there have been no studies that have really shown community health impact. So there have been a number of studies that show improved patient health. So again, Sanjeev Arora's study in hepatitis C. There was a study in diabetes care looking at hemoglobin A1C levels, and in dementia, decreased hospitalization and improved behavioral issues for providers that participated in echo for all of their patients. Sorry, for their patients that were presented on echo. Community health would be, does this generalize to the whole practice? And that's certainly something we would like to get to. And so we have adopted the same evaluation framework for our own program, and in fact the University of New Mexico has now adopted this model. And so far we've evaluated levels 1 to 4, and we have different projects underway looking at performance. We're using simulation via video to look at increased or enhanced clinical performance by providers who participate on echo. Patient health, we're collecting outcomes of patients that are reviewed on echo, and then community health. We're very fortunate in Ontario to have administrative data available through ISIS, so we can look at larger impacts of this work depending on the providers who participate in echo. So I'm going to skim through some of this, but these are the examples. So we have good participation in echo across the 3 cycles. You can see as we've actually gone further along in cycle 3, we've moved further north. So it's like the avant-garde. We're moving further and further north. We've had exactly 336 participants so far in echo, and they're a very diverse interprofessional group. Initially we were aiming for physicians, but in fact we found that it's really, nurse practitioners are our number one profession that participates, and often they draw the physicians in when they're presenting their case, and the physician wants to be present. But a really wide group. We're also, our whole group did a data analysis with Paul Kurdiak, looking at who were the sites that, because a bunch were invited to participate, who ended up participating of those who were offered. And fortunately, those that are more rural and those that work in interprofessional teams, those are a big draw to participating on echo, and we're going to use that as a baseline going forward to look at how echo spreads. People are very satisfied with it. They gain knowledge, so pre and post testing, there's a significant knowledge increase over the course of participating in echo, and we're now doing 6-month follow-up to see if they retain that knowledge gain. And this is something newer that we're looking at, is recommendation implementation. And these spokes, they're so amazing and intrepid. They implement about 60% of what is recommended, with a plan to implement a further 20%. So that's a large difference from just doing a random consult. The other thing that we're looking at is how do the recommendations that are made on echo fit with these quality of care domains. I won't go too much into that, but it's very interesting. What's recommended tends to fall in the area of effectiveness, safety, and patient-centeredness. So it's particularly good at targeting those areas of quality improvement. And I've mentioned some of these other things that we're looking at right now. The other thing I won't say too much about, but we have become a super hub. That is a University of New Mexico term, one I love to say, obviously, where we can train people to become echoes, because echo is really growing in Ontario. So we're partnered with UHN, and we have 9 total mental health echoes that are rolling out over the next year, and then a whole host of physical health-oriented echoes. And we're also trying to cross-pollinate. I know Peter has been very involved in echo as well. Trying to cross-pollinate to get at that idea of integrated health and addressing both physical and mental health. So we're frequently asked to present on these other physical health-oriented echoes. But it turned out, I think, bigger than anybody ever thought, for better and for worse. All right. I want to mention 2 other areas of trying to research outreach that we're doing, again, looking more at systems planning and the economies of scale of outreach. And these are 2 studies that Eva Surhall has led. This is what we do. People come onto the team and then they do PhDs, so join us. So with this telepsychiatry study, we used ISIS data to look at who were the physicians providing telepsychiatry in Ontario and who were the most at-need patients actually receiving telepsychiatry. And quite disappointingly, the uptake is still very, very low. Only 7% of psychiatrists provide telepsychiatry, and only 1% of the most at-need patients receive their care via telepsychiatry. So it's really not reaching those most at-need populations. And even more, you won't be able to read this, but this gives a sense of the whole thing. It's a scattershot of systems planning. There's really no rhyme or reason as to who provides telepsychiatry, from where to where. We had LINs that were swapping telepsychiatry, where one LIN would provide telepsych to another, and that LIN would provide it back to that LIN. There's really not a lot of system planning, and low uptake. So there's a lot of room. I guess that's the good news. There's a lot of room for improvement in telepsychiatry, and this kind of health systems data is going to help us do that. And then looking at the economics of outreach, there is some study in this area, including a Canadian study. Again, O'Reilly looked at the cost savings and found about a 10% cost savings. That tends for telepsychiatry, and that usually is the case when the farther out the patient is, which makes sense, and the larger the volumes of telepsychiatry that you do. But what we're interested in is comparing the three different modalities. So telepsychiatry, patient reimbursement, when they have to travel, the patient reimbursement program, that's the blue line there, and the fly-in, drive-in. And you can see here the kind of break-even number. So the number of consults you need to do before telepsychiatry will start to show an advantage. And you can see the more you do, telepsychiatry does end up becoming a cost savings. And certainly both models are a cost savings compared to having to pay patients to travel. And if you have more detailed methodological questions about this study, ask Eva. I can barely read the graph. Okay, and then the last part of this section anyway that I want to get at is, if we think about CAMH and CAMH having this outward-facing provincial mandate, I really see outreach as a way to do that, but there are also a lot of pitfalls. If we're not engaging in that system planning, then are we really making a difference? And are we using our full power, I guess, is a better way to put that, in our full potential, which we could achieve through integration. And we should even think even more broadly in terms of all of the different and growing e-behavioral health services. So lots of people at CAMH are developing apps or developing CBT delivered by something. It's something to work towards to try to unite all of these different technologies and modes of serving outside of the GTA. And there are some people in the States, again, mostly through the VA, that are doing this multimodal work and can guide that practice. So if we look at that map again, as I said, are the communities that get all three, are they really doing any better in terms of mental health outcomes and access to mental health services? Because sometimes we are in that community, but we're also working with different providers in the community. And again, even at that local level, may not be getting the full strength that we could. So this is what I hope we could work towards and envision, that we have somebody helping step patients through these different modalities, someone seeing, what's the severity, what modality could best serve this patient, and the provider referring the patient. That we have tools that are accessible for patients and families to do self-management. There's, growing evidence for that. And that we can also work on capacity building through ECHO within the community so that providers have a kind of anchor and they can refer from there and know our services from that point. And not to do away with the fly-in. People have very long-standing relationships with communities that build trust, but to integrate it a bit better so that we don't have to do all of the work by flying and driving. And within this, as I've said, if we can focus on quality, on measurement-based care, health systems planning, and also community specificity, this is a very relationship-based service. There are two other areas that were very related that we're involved in. I probably won't have time to speak too much about both of them, but one is the outreach that we do to First Nations, Inuit, and Métis communities in Ontario and Nunavut, and how these programs are relevant and how they need to be adapted for those communities. and then the education that we do for residents and providers. I think that I'll spend the rest of the time focusing on this, and then if you have any questions about the education, I can talk about that. And I really wanted to tell you about my dissertation research, because this is where one of my interest in this changed. Moving away from seeing outreach and providing care as always positive. Like, we really have an impact, and sometimes that impact can have unintended consequences. So what I did was I looked at physicians who wrote about their medical experience in what's now Nunavut over the last 100 years, and looked at the ways that they talked about different eras of healthcare, the way they talked about Inuit clients, and the way they talked about their own professional identity formation, like how reflective they were. And really found overwhelmingly, I had this kind of early hypothesis that, I'd read these books and see this great progress in the way that we provide outreach. But in fact, there's a lot of echoes of the same ways of thinking about the others that we provide care to. So outreach, particularly when we were working across cultures and with cultures and communities, not just cultures that have disadvantages, what is that like, and are we maintaining those power structures when we go in and provide outreach? So I won't read these quotes, but essentially these physicians talked about Inuit as if they were vulnerable, childish, uncivilized, and that's right up until 2008. And they talked about themselves. In fact, there is a whole analysis in photographs that was very revealing. The kinds of photographs that these physicians would put into their memoirs really depicted themselves as very powerful and very robust and adventurous out in the Arctic. But there were lots of patient photographs, and always in states of undress, very vulnerable. That really, I think, rationalized a lot of the forms of care that happened for Inuit over the last 100 years and contributed to a lot of social suffering. So with that note, how can we engage in that kind of care? And I want to talk about two things. One is by engaging, community engagement in a way that respects people's autonomy and finding out what wellness means to communities. This was a study done by a student I was working with. She interviewed elders in a Nunavut community about what wellness means for them. So we invited Inuit counselors. There's a kind of budding program that trains Inuit to be local counselors, and some are elders, and asking them, what was important to them and what did they see contributing to wellness. And that project's now going to expand to the circumpolar context, because there's a lot to learn, not just nationally, but across these contexts globally. So you can hear from that, that is a form of engagement. It's a way of engaging people in their own wellness and health care, and recognizing their strengths. It's a very strengths-based approach, because it's very difficult, the kinds of stories that come out, but also the resilience of people. And then involving them, using that as a platform to involve people in their healthcare more directly and setting priorities. It's also a means of qualitative research. We found out a lot of different things about wellness means. It's certainly not sitting in a clinic for 45 minutes. And there are ways that we can, actually I'm going to just flash forward to this slide. There are ways so we did a study looking at adapting trauma-focused cognitive behavioral therapy, but in a way that brought people out onto the land, that increased connectedness between people. So there are ways that we can then take that information and make the work that we can provide more meaningful. And the same thing on ECHO. So at CAMH, we've developed a First Nations, Inuit, and Métis ECHO, and through that, our hub is an integrated, people want to receive care from members of their community. So we have an elder, Indigenous social worker, and other members of the Aboriginal Education and Outreach Program that participate. And our approach to integrating knowledge is very broad as well. We also use traditional Indigenous knowledge to reflect on cases, as well as evidence-based practice. So I'll leave it there, other than to also say that education, I think, is really important. That's why we have these outreach programs. That's why the ministry has put them at universities and teaching hospitals, because there is evidence that people who are exposed to this kind of work go on and do it as part of their practice, but we also can play a role in teaching students these unique skills and helping them to reflect on their impacts when they go into different communities. And we've done some work around that, around defining those competencies for telepsychiatry, and we're doing that with outreach right now. That's it. Thank you. That difference between the implementation of 60% of the recommendations by primary care providers that are present on ECHO versus usual care. And the question is why? Why that jump? And I think your point is a good one. They're all hypotheses at this juncture, but yes, they're probably getting recommendations that are more applicable to them, things they can actually carry out in their communities, because again, that knowledge is flowing back to us as well. We're not saying, do the full course of dialectical behavior therapy that is not available in their community. We're saying, here's a book to implement this piece of dialectical behavior therapy, and maybe someone in your community should get training. So it's much more specific. I think that's a good point. And they feel empowered to do it, I think, too. They know they can bring it back to ECHO and get, okay, start lithium is a bit overwhelming for most primary care providers, or clozapine. But if they can bring it back and check in, it feels more manageable, I think. The question is really about the low participation or the low provision of telepsychiatry by psychiatrists in the province, and then at CAMH, where we have a lot of, how many psychiatrists do we even have?
Over 300.
300, yeah. So we have a lot of psychiatrists at CAMH, and do even 7% of them participate in telepsychiatry? Not formally, for sure. So we're probably lower than the average, although we do the highest volume of telepsychiatry of anyone else in the province. We're probably neck and neck with sick kids in the child, and the other important thing is they're not captured in this data because it has to be through OHIP. So
you have the biggest pool of providers.
Yes, we also have the biggest pool.
How many total numbers of psychiatrists do it?
We usually report around 280.
No, how many psychiatrists?
In telepsychiatry? Well, 30.
30 and 40.
Yeah.
30 out of 300 would be 10%.
Yeah, so that's pretty good. That's what I was going to say. Yeah.
30, that's actually a high number.
We have about 10 core people. Yeah.
There's tons of capacity.
And
the technology could enable that, and current advances in how technology could enable some of this.
Yeah. With the caveat that, just doing more consults, I think these other planning and working with local communities and having continuity of care for clients is really important. I think that we've been not as great as we could be about being interdisciplinary. ECHO certainly is interdisciplinary because the ministry supports that. But in outreach, it's really been psychiatrist heavy, and that's a real shame because it's not the model of care. We do tend to form interprofessional teams at a distance, like the other professionals are at the distal site, but we've only taken psychiatry residents and occasionally med students, but we certainly should look at that.